The neurological examination of the arms is a critical skill both for medical students and residents. This examination assesses motor and sensory functions, reflexes, and coordination to identify potential neurological deficits. Begin with a thorough inspection for muscle atrophy, fasciculations, and asymmetry. Evaluate muscle tone by passively moving the joints, and test muscle strength using the Medical Research Council MRC scale. Assess reflexes, including the biceps, triceps, and brachioradialis reflexes. Sensory examination involves testing for light touch, pain, temperature, vibration, and proprioception or joint position sense. Mastery of these techniques is essential for accurate diagnosis and effective patient management.
Introduce yourself and explain what you'll be doing. Spend some time on inspecting. Carefully look for any abnormal posturing, any involuntary movements, and then try to elicit the involuntary movements of fasciculation by tapping over the muscles. Check for the bulk. Compare the bulk on the two sides, maybe using say tape measure or just by say estimating. Check for any presence of any tremors. Notice the tone by passively moving the limb at each joint and noticing the resistance offered by the patient or the net stiffness you find. So you may have an increased tone or rigidity, or you may find a totally flaccid joint which are not offering any resistance to any movement. Check for the power first by if your patient can lift it up to against say gravity, it's grade 3 power. Now check it against resistance, so at each group of muscles at each joint. Now this is checking for the abduction of the shoulders, checking for the adduction of the shoulders, again the abductor of the shoulders, checking the power in the flexors of the elbows. And if you find the power equal to u, or its normal power, it is graded as from 1 to 5, it's grade 5 power. Now this is long flexors of the hands, the checking power in the long flex of the hands, checking for the abductors and adductors of the fingers, the introssei, checking for the again the adduction using the card test, that your patient can pull it with the same force using your same hand and the same group of fingers for each say introssei. Checking for the small muscle of the hands, opponents, adductor of the thumbs, this is the flexors of the wrist, extensor of the wrist. By asking the patient to flex the fingers, you take away the long flexors or the small muscle of the hands out of action, and it's just the long flexor instead of being checked. Now check for the reflexes, tendon reflexes. Checking for the biceps by placing your thumb or finger over the bicep tendon and striking over your thumb. Note the contraction. This is checking for the brachioradialis or the radial jerk, and this is where you strike for the triceps jerk. Notice the contraction, notice the grade the reflexes from 1 to 4, the 1 being 0 being that you don't find any contraction or movement, and grade 4 would be when you have a brisk response. This is demonstrating again, checking for the reflexes. This is a demonstration of the Hoffman sign that if you flex the distal phalanx and then forcibly flex it, the normal response is there is no flexion of the this thumb or the little finger, but in patient with upper motor neuron lesion, they would have an adduction of the thumb and the little finger, and this is an equivalent of Babinski sign in the lower limb. Now, first, when checking the sensation, first you make patient aware that by touching it over the face, that this is the kind of sensation you would be feeling. Ask him to close the eyes and check for the light touch using cotton at each of the dermatome, starting from the hand. This is soft touch being checked using some kind of a not very sharp but a bit, must say, uh, pointed like toothpick. First make your patient aware that if he can feel that, and that better that he feels it or whether it is a sense of a pricking, which is pricking is more of a painful sensations. Again, touching it at each dermatome. Now this is the dorsal aspect of the hand. Comparing it with the opposite limb is always to be done. And if you find any deficit, you describe it. Either it would be following a nerve pattern or it may be following a nerve pattern. This is checking for the vibration sense. First, you make the patient aware that this is the kind of sensations you will be feeling, and then after striking it over your hand, you place it over the thumb and ask for the sensations, vibratory sensations, if the patient feels it or not. Again, it's important that patient may be feeling, you just after say striking and the vibrator vibration started, you stop the vibration by your hand, so that if he still feels the sensation, that may be abnormal. So if doesn't feel, then now this is the time to check for the coordination or finger nose ataxia. So you explain to the patient you must be standing at least one arm length from the patient and ask the patient to touch your finger and the nose uh, in succession rapidly, and you keep on changing your position of your hand so that he has to follow it, and note any say past pointing or overshooting or any dysmetria. Check for the tremors. Again, another way is that you ask your patient to hold the hand and close the eyes, and then by disturbing, you would be noting it that there is, say, he may be feeling ataxic.
In summary, the neurological examination of the arms and hands should focus on muscle strength, tone, and bulk, reflexes, and sensory function. Key features include assessing for muscle atrophy, fasciculations, and asymmetry, testing reflexes such as the biceps, triceps, and brachioradialis, and evaluating sensory modalities like light touch, pain, and proprioception. For conditions like motor neuron disease and neuropathies, imaging tests such as MRI and nerve conduction studies NCS are invaluable. MRI can reveal structural abnormalities, while NCS assesses the electrical conduction of nerves, aiding in the diagnosis and management of these conditions.